special one of Save My Piggies. Now, I'm not going to ruin the surprise for you. I have the information, but I want you to listen so that I know you're getting the correct information. I know you're getting good information. I know you're getting treated correctly. We have a little bit of time before we start this, so I just appreciate and pray that you all come together during this month of giving. Come together to find out more that you can do for your family members that might have these ailments and do what must be needed to be done. We have, well, roughly 10 seconds or so before we start. Thank you and take care.
With our mobile app, KDOW.biz, tune in, iHeart, and the Odyssey app. AM 1220 KDOW.
Sponsored by The Way to My Heart Incorporated.
Welcome to the Heart of Innovation, 60 minutes that could save life and limb, with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by Patient Advocacy Group, the Global PAD Association at padhelp.org, in partnership with Reflow Medical, the pulse of medical ingenuity. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of the Global PAD Association, Kim McNicholas, and interventional cardiologist and founder of Save My Piggies Health and Wellness, Dr. John Phillips.
Hi, everyone, and welcome to the show. We have a really special show planned. It is a Save My Piggies edition of the Heart of Innovation, and that means we are going to be featuring a harrowing story of a son fighting for his dad's legs, trying to save his legs from amputation with a disease that is more prevalent and deadlier than most cancers combined. It is called peripheral artery disease, and it is poor circulation in the legs, in the arteries in the legs, and it's caused by plaque buildup. And you might notice some fatigue in the legs, leg cramps, leg pain, tingling, numbness. It might not be old age. It might not be diabetic neuropathy. It might not be just a spasm or restless legs or sciatica or spinal issues. It might be peripheral artery disease. And because so many doctors end up brushing off these symptoms as other ailments, peripheral artery disease in so many patients across the globe ends up progressing to critical limb threatening ischemia, or CLTI, also known as critical limb ischemia, or CLI. And that's where these patients are at risk of losing their leg, and there are very few options available, with very few doctors who have what are called Hail Mary options. And we have one of those doctors that has a Hail Mary option for these patients. It is Dr. Zola N'Dandu, and I'm so honored to have Dr. N'Dandu here. He is from East Palatka, Florida. That's where he actually practices. He's also on my board of directors for the Way to My Heart and the Global PAD Association. Just full disclosure, but we are so honored, Dr. N'Dandu, to have you here today. Dr. John Phillips has the day off. He's somewhere across the globe saving the piggies, but thank you so much for pinch hitting and being here and sharing the story of one of your patients' journeys.
Thank you very much. Thank you for having me here. And it's truly an honor to be here today.
So I think that we should get right into the story, but first let's kick things off with a moment of inspiration.
Dr. Zola N'Dandu's spectacular vascular moment of inspiration.
Well, thank you. I like that introduction. That's pretty nice.
I think Dr. Phillips is going to be so jealous. He's going to think someone is stealing his job away.
Yeah, no, this is great. It's like a movie of some sort.
No, thank you to Colin, our producer, for making that happen so last minute and giving Dr. N'Dandu such a warm welcome.
Perfect. No, thank you. But on a serious note, considering what we're going to discuss today, especially the patient journey through this process. So we as medical professionals, we talk a lot. We have all these fancy terms, all this vocabulary that we use, all these procedures that we do sometimes, even we don't understand, let alone our patients. So it's nice to get a perspective from the patient, to hear their story. So that's where the Hortons family are going to explain to us their journey up until this point. But if I have to share a moment of inspiration, lately I've been reading a lot from Dr. Eddie Glaude out of Princeton, And there's one thing that he said that was quite interesting that I really like that says, hope arises when you don't ignore challenges, but instead when you face them with courage and commitment to change. And this is the approach I think we should take for a lot of our complex CLI or CLTI patients. And hopefully this story that we're going to share today is reflected in this moment of inspiration that I just shared with you. Thank you very much.
I think that that is absolutely brilliant, and it's the perfect quote to be sharing for this journey. And it's, you know, you're on the front lines every single day fighting for life and limb. And what is that number one thing that people want? They want hope, and they get hope through a doctor becoming their partner in care and fighting right alongside them and making that commitment that they're going to do everything in their power that is available to try and save their limb. And that's really what it's all about, right?
Yep, absolutely. Absolutely.
And it's hard to believe that there are a lot of doctors out there that don't adopt a lot of these advanced options that are available, you know, waiting for the evidence instead of helping to create the evidence. If someone's going to lose their limb anyway, Dr. N'Dandu, why not try?
Yeah, I mean, I think that's really important. And that's really for every field. It just so happened that we're talking about peripheral arterial disease, we're talking about CLI and CLTI, but I think that's in every field. So I think it becomes really important for those that are working in the field to obviously continue working, to continue improving, to continue innovating, to make things better. And when it comes to CLTI, we have obviously a lot of work to do within the medical community itself. So we need to educate other physicians amongst ourselves. But also we need to educate the community at large to know, because many people are not aware of the implications associated with CLTI when it comes to the morbidity associated, the mortality associated with it, what it means when you have a wound. By the time you have a wound, we know from a diabetic standpoint, within a year, a quarter of the patient are probably going to be dead, a quarter are going to be amputated, a quarter are going to have a limb with a wound that has not healed, and probably a quarter are going to have a wound that's completely healed. So these numbers are quite astronomical. And so I think it becomes really important to make sure that we do the right thing, trying to help as many people as possible. So
many doctors say, why delay the inevitable? And I think you made such a powerful case that there is a reason to delay the inevitable. If amputation is the inevitable, it's important to delay it.
Yeah, absolutely. So if somebody's facing an amputation, and if it can be prevented, then obviously we need to prevent it, because we know it sounds fairly simple. And I'm sure the Horton family are going to share this, Sam and Samuel, that among the many discussions that we had, one of them was, as we start talking about mortality and morbidity, the question was, well, if you amputate the leg, you have less body parts. What does it translate into dying? And I think those are among the many things that sometimes we don't do as good of a job of explaining and describing. But really, it's reflective of the global illness throughout the body and all the other comorbidities that comes along with getting an amputation, from being debilitated, from having risk of other infections, what I call casualties of war, which then ultimately can lead to death. So really, really important to prevent that at all costs. And obviously, if you can prevent things upstream, meaning dealing with all the risk factors before they get to the point of becoming CLTI, even better. And so that's why it's so important to really address this from a multidisciplinary standpoint as a team, where you have, you know, the vascular specialist, you have the primary care, you have the podiatrist, you have a nephrologist, you have family members, you have social care or social managers or case managers, I should say, you have home health nurse. I mean, really, it takes an entire village to have a successful story if you're going to achieve that.
It does. And coming up right here on the Heart of Innovation, we're going to meet Samuel and Sam and hear their incredible journey and how Dr. Zola N'Dandu took his case head on, faced the challenges to give this family hope that the dad would remain on his feet and continuing to walk to live another day. So stay with us. Yay.
Yep.
So fantastic. So we're going to go right into bringing him in, and in the next, it's always nice to start, you know, fresh with the segment 2, We usually kind of chat away in the first break, but we are now going into segment 2, and we are going to start the story. So as soon as we come back, we're going to welcome both you, Sam and Samuel. Do we know which one of you wants to? We'll welcome you. You guys can just say hello, and then Dr. N'Dandu.
Yeah.
Don't wait for me. I don't care if we're like the firing squad and we're each kind of almost jumping on each other to ask them questions and share. Just jump in. It's literally it's you and me co-hosting today. Even though I will be asking you to start the story. What do you think about me letting I'll open it up and introduce you to kind of start the story?
Yeah, that's fine.
And then you can introduce both of them.
Absolutely. Yeah, that's
Okay.
perfect actually. Yeah. And then we'll let them tell their story and go from there. And then if you want me to, I have a few slides I can talk about briefly what we did from a slide standpoint, if you want me to.
Yeah.
And or we just keep it verbal, that's fine too.
No, that's great. Just remember we're on the radio as well.
Yeah.
And so
Yeah.
all we have to say is, and for those of you who are listening on the radio, make sure you go to YouTube, our YouTube channel, and I can give it and they can see those slides.
Perfect. Sounds good.
Later on.
Okay.
So makes it really easy. And that was a perfect wrap up, and the quote was absolutely perfect. So amazing. And this segment, how long is this segment, Colin?
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone, and welcome back to the Heart of Innovation. This is our Save My Piggies edition. Dr. Phillips, unfortunately, has the day off. He's off somewhere across the globe saving piggies, but I know he wishes he could be here to hear this amazing story that we are going to be sharing over the next 40 minutes with Dr. Zola N'Dandu. He's an interventional cardiologist. He is what we call a CLI operator, CLI fighter, critical limb ischemia. It's the most advanced stage of peripheral artery disease, that poor circulation in the legs. And Dr. N'Dandu, I want to kick it on over to you to start the story and to, with this family sharing their journey that ended up with you saving the leg.
Okay, great. No, thank you so much. This is a fantastic opportunity, as I mentioned earlier. So many times as medical professional, we talk amongst ourselves, but we don't understand what does it mean to patients or the journey that our patients and families go through. So I have an amazing opportunity today to introduce Mr. Sam and Samuel, the third and the fourth. So Samuel is the father, Sam is the son. And this is the family that we met. They were all the way in Pensacola, reached out to me after seeing one of our presentations online. And they had my cell phone in my email. They contact me going through some of the challenges that we're facing. A non-healing wound for a few months, unfortunately without standard revascularization options in terms of balloon angioplasty. So within the endovascular umbrella or surgical umbrella. And they say, hey, we saw that you do DVA work for last options to prevent amputation. Anyway, you can take up my father to help. This was a Sunday afternoon. I'm sitting on my couch. This is a text message from somebody I've never met. And so we started connecting, and here we are today. So I have the honor and the privilege to introduce both son and father for them to tell us their journey, how things started, and where we are today. And hopefully this will be an opportunity to teach us as medical providers and other people who are here to learn, and hopefully one day also save another family member somewhere who might be going through the same trouble. Mr. Sam and Samuel Horton, please. The stage is yours.
Well, thank you, Dr. N'Dandu. I'm Samuel Horton, Sr., or the third, and this has been absolutely an amazing adventure or journey. I had been home in Pensacola doing things to try to help my health, but it was only because of the intervention of my son into this process that I still have my leg and my foot today. So he's been an amazing and wonderful son who looked after the details that I couldn't see. And Sam, you say something?
Well, it was a very, in some ways traumatic, in some ways, you really don't know what's going on. We had been communicating with my father. I knew that he was going regular to a podiatrist, and he was, I knew, you know, I think everybody in their life's journey is really busy, and we don't really get until we really understand the seriousness of certain things. We don't dig as deep as maybe we should because we're all so busy. I knew that my father had been going to the podiatrist. He would tell me that he was having some cutting done on his foot, that he had some issues with the ingrown toenail. And he was saying that he was in pain. And you really don't understand. You think it's associated with the foot. And, he was going to the podiatrist on a regular basis. No real, hey, this is really serious, or it's critical limb ischemia, or what the risks or anything. He's had diabetes for some time. He's going to dialysis, and in relatively good health. Outside of going to dialysis, I mean, he did have some other challenges, but when I was getting ready to go out of the country, and I called my dad for last time, hey, I'm about to go. And he tells me he's got to go tomorrow to get his toe amputated. Didn't know what was going on.
That had to have come as a big shock. I mean, you think he's going in for just an ingrown toenail and then getting that cared for, and then suddenly, well, we got to remove a limb.
Yeah. So fast forward, we canceled the trip, get to Pensacola. I don't know, we don't really have a lot of time, but there was just a lot of different things going on outside, because I think you assume that certain things are going on, but you really don't know everything. But anyway, I arrived the next morning on a plane. We got to the emergency room, necrosis, never really seen a limb like that before, toe totally black. Doctor, I'm not sure if we would show those pictures, but
I do. I will.
Yeah. And so that toe was totally black. It's kind of traumatic to see something like that. There were other issues. His hemoglobin was really low, bleeding in the stomach, different things. The doctors there just said, hey, that's got to come off. And we went through that process of going in and out of different procedures to have the amputation. There was a lot of different steps that I think, looking back at it, that weren't done correctly. He was having what I now know as rest pain, a lot of pain in his foot. And the thought was in his leg, the thought we were thinking at that time, at least I was thinking, hey, once the amputation is done, this is bad. But once this amputation is done, the pain should go away. And it didn't. And it continued. And so we were sitting in the hospital without the ability to really see other doctors or get other opinions, ask for second opinions. And this pain continued to go forward. And after, going back and forth with these different professionals, nobody had a solution. And not only did they not have a solution, they really were not pointing us to anywhere for a solution.
Yeah. Hey,
Uh,
Sam, quick question. What we're gonna do is I'm gonna ask you just to rephrase that in a second, and then you take us to the next session in a few minutes here. And we might have a few questions also as we're just starting, but it's so important some of the things that you mentioned. So we'll come back in the next session here in a few seconds. That way we get to pick up where you left off in terms of the sense of being lost. I think a lot of people don't understand what that means as a patient, as a family member. So we're going to want you to elaborate more on that because nobody should have to go through that.
Nope.
And
And
just,
so we're going to head to break and we'll be
yeah.
right back right here on the Heart of Innovation on KDOW. Don't go away.
3 years.
Nice job, Dr. N'Dandu.
Now, I saw that that's about 30 seconds. And the Hortons, both, I really want to thank you for sharing that because, as I said earlier, this is the part, especially, I can't wait to share this with other doctors. This is the part as doctors we just don't understand. We don't see this. We walk in the room, we talk with you a few minutes, we walk away, we go to the next patient, to the next patient, to the next patient. But people don't realize the people that you left behind in that room, what's going through their head. And so hopefully it's going to be an opportunity to teach many people what it means because we just don't do as good of a job. And I really appreciate you sharing exactly what that means. And anybody who doesn't understand that fundamentally has a problem. So
yeah, it's so important. And this one, we only have 5 minutes, 30 seconds in this particular segment. We're in segment 3. And so we'll come back and I'll just toss right to you, Dr. N'Dandu, to lead them into the next part of the story. But I'm curious, I also want to know, I mean, at what point did they realize that it was a vascular problem? Because it seems like, okay, so they cut off the toe. What were the procedures? There seemed to be a bunch of procedures. Was that because they knew that they needed to open up some of the arteries? Did they try? What did they try?
Yeah, no, they did all that, and I'll let Sam Horton explain those things because he by the time he and I were speaking, he was able to give me all those details before Mr. Samuel came on board. So he will go through those details for us. And somebody asked a question: is there a difference between in the African American community or not? I'm gonna talk about that. And then somebody asked about advocacy, and obviously we're an advocacy group, so we're going to talk about that as well. So Douglas, I really appreciate those questions.
It seems to me the problem that people don't know what they don't know.
That's exactly it. That's it. Even when people have good intentions, if they don't know, they don't know. They don't think anything can be done. I just did a case this past Wednesday, and a lady had been in pain since May. Why am I doing this in December? That's exactly it.
Wow.
Yeah. Young lady, 58 years old.
Yeah, I just had this one. The poor guy lost his leg last week in Naples, Florida. They actually told me at this hospital that they no longer do CLI work because the reimbursement's not there. And so it's not worthwhile. I couldn't believe I actually got that message in a text. It was candid, it was truth. But by that point, the patient was already in so much pain, and we couldn't get him out of the hospital. I mean, he was just immobile. And the thing is, I don't want to tell people not to go to the emergency room because that's a huge liability. You always, if you think you're having a medical emergency, you need to go to the nearest emergency room. But by the same token, what would deem an emergency, right, in these cases? And that's always tough to tell. We have a lot of patients that don't even have, the wound on their foot. They end up in a lot of pain. They go to the emergency room.
Yeah.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone, and welcome back to the show. Dr. John Phillips has the day off. He's somewhere across the globe saving the piggies. And speaking of saving those piggies, we have a special Save My Piggies edition of the Heart of Innovation today. We are featuring the Horton family, and also my guest co-host for the day is Dr. Zola N'Dandu, who was able to save the leg of Samuel Horton, who was on deck for amputation due to peripheral artery disease, its most advanced stage, critical limb threatening ischemia. And that is poor circulation in the legs that gets to the point where there is just your nerves, your tissues, your muscles, everything are just screaming for oxygen, screaming for blood flow. And so there are a lot of doctors out there that at that point, they'll just say, you know what, we can't treat the patient below the knee and we're just going to cut off the leg. But they're amazing advanced limb salvage specialists known as CLI operators, CLI fighters. And one of those is Dr. Zola N'Dandu. I'm going to let him carry on with the conversation with Samuel Horton and his son, Sam. Go ahead, Dr. N'Dandu.
Perfect. So on the last segment, Sam, you mentioned some of the challenges that you face as a son, as a loved one, as a family member, trying to address your dad's health issues. So I want you to break down to us in terms of those challenges and some of the procedures that he went through and what transpired thereafter. Please, the stage is yours.
So we, as I stated, we had the amputation. One of the things that was told to me was, the healing was going to be based upon how much blood when they did the amputation, whereas they should have, or the original procedure would be to clear the arteries and do some of the arterial revascularization procedures prior to the amputation. They chose to do the amputation first. When they did the amputation, there was no good blood flow. They went back in, they attempted some additional revascularization with his previous doctor, who he had been seeing prior to all of this, who had told him previously that the blood flow was good. He had been working with a vascular doctor previously, who, when they were doing the minor amputations or the cutting, had said that he had good blood flow. Obviously, that wasn't the case. I think they had done another procedure where they had went in retrograde. I didn't understand this at the time, but previous to the hospitalization, they had tried a revascularization procedure, which is called a retrograde procedure, where they go into the foot as opposed to in the leg. When they did that procedure, my dad had complained of his foot went cold. I didn't understand what that meant, but looking back, that procedure had caused the issue, which eventually led to speeding up of what eventually happened with his toe being in a necrotic state. So I continue to ask for alternatives. How can we get more blood flow? After doing more research, nobody had even used the term critical leg ischemia to us or to me. And we're going through, they had a hospitalist who was not experienced, who was just the kidney doctor, because he has dialysis. They put the nephrologist in charge of his overall coordination of care. So I was sitting there talking to all the different specialists, because the nephrologist really even complained to me directly that he was only doing this because the hospital forced him to be the one coordinating. So he really didn't have a specialist, a understanding of the options. When we demanded a second opinion from a vascular surgeon, they had no idea what before I knew about what DVA was, the term DVA, I had learned that there might be a procedure where you could use a vein as an artery. And I kind of spoke with him and said, well, we think, I don't know, but maybe there's somebody in Tallahassee. I'll talk to my boss and get back with you. But we were basically given no options and sat in the hospital for weeks with nothing going on until we were finally discharged to a rehab, still with rest pain, still with no resolution of the underlying cause, and pretty much on a path to an eventual amputation.
And coming up right here on the Heart of Innovation, we're going to hear how he found Dr. Zola N'Dandu, who could perform this deep vein arterialization, or DVA, where they hijack a vein to take blood flow and reroute blood flow from a blocked artery in the calf all the way to the foot to help get a wound on the foot healed. So stay with us right here on the Heart of Innovation and our special Save My Piggies edition. Next. Awesome. And I think we have 9 minutes in this next segment.
Okay.
So it's our long one. It's either 8 or 9 minutes, so it's a little longer. This is our second to last segment, but we can wrap up. We can get through it. It's still, it feels usually long once you're in it because it's like 8 to 9 minutes. And then we have a 4-minute segment. But if we feel like there is some grander issue that you want to address beyond the story, we can stick around after the show ends and we can continue with the live stream and just continue asking the questions that you want to make sure we get them all in. And I can edit it into the final show later that we post. Does that make sense?
Yeah.
Yeah.
Kim,
Yes.
so for the next section, I'll have Sam briefly talk about how they found me, and then I'll talk about how we met, and then I reduced the presentation I made it very, very short just so we can kind of talk about what it means to have the situation Mr. Horton presented with and what we did, and then go from there. So I have a couple
We have
pictures.
6 minutes and 30 seconds in this segment.
Okay.
And then we
I'll
have
keep it
4.
really short.
Yeah, and then we have 4 minutes. And then, as I said, if we have grander issues, like Douglas brought up some grander issues that might be interesting to add in later, we can address those after the show and just continue to go live on YouTube and record to re-edit it.
Okay, perfect. So I'm gonna have Mr. Horton talk about how they found me, and then we'll pick up from there. How about that?
Yeah, and I'm curious, Sam, just we're not on the air yet, but do you know which video or that you found of Dr. N'Dandu's and where he was presenting this?
It was a presentation to some other clinicians while he was still at Ochsner, I believe, and I'm sure I could find it back in my history. It was back in June, but I'm not sure which one.
Because I know he did a presentation for our organization as well, so I'm always curious if it was one of our videos where he was presenting DVA.
Yeah, I mean, he was there in person. It seemed like it was a live crowd, or seemed like it was more of a
conference.
A conference.
Yeah, so it could also be in that NCVH, because I presented a lot there, and I presented the AMP as well. So it could be any one of those. We're good.
Yeah. Darn. we always like when people find us. We just had someone find us yesterday. She said that she has spent the last month scouring our YouTube videos and just watching one after another. And she said she's got more information there than she did with her own doctors. Right. And so she finally gave our organization a call because she wanted to watch enough videos so that she had a list of questions that she could ask me. And so she called yesterday, and we're going to find her a different doctor with some new options for her. But I thought that was kind of cool. YouTube's such a great resource these days. So much, right? And that's interesting that you went to YouTube. That was so smart to go to YouTube versus going to Google, where they have sponsored results on Google versus on YouTube. It's so much easier to find the real deal.
Right. Well, I went to everything. I went to Science Direct. I mean, looked at papers and articles from a lot of different places, but YouTube was just one of them. But yeah, spent a lot of time on YouTube.
No, very, very impressive. Absolutely.
And I'm so sorry that and I see this all the time, I'm so sorry you got stuck in the hospital and you probably, just sitting there. And I hear this all the time with these patients that they just sit there and sit there and sit there and no one has a plan. And they'll say, well, you know what? We're just going to make you sit here until you decide that you're going to amputate. Until you're going to let us take the leg, we're just going to let you sit here. And meantime, they won't discharge you. They'll only tell you that if you leave the hospital and they do discharge you, it's going to be AMA, against medical advice, which then puts you in jeopardy of the next place that you go to get help, that your insurance will not cover it. And it's a vicious cycle, and it's so hard. And I'm so glad that you guys came out on the higher end of things.
They did the exact same thing to me.
Yep.
Yeah, that's what
There's
we just
so many
had with
levels
this.
to the story. I know we don't have the time to talk about it, but we can't talk about that because it's just so little time. But we went through a similar thing at the rehab facility, not at the hospital. The hospital had no plan, period. They just were waiting because they couldn't figure out how to get us to the rehab, and I kept on complaining and asking questions, so they couldn't really discharge him until they got him stabilized, and then they just again didn't have a plan. So
Heads up, everybody! 5 seconds till we air.
Okay.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone, and welcome back to the show. We have a very special Save My Piggies edition of the Heart of Innovation. Dr. Phillips is off saving some piggies, but we are very honored to have Dr. Zola N'Dandu here with us today, guest co-hosting, and he is also here to help us share a very special story, harrowing story, of one of his patients and the son of the patient fighting to save his dad's leg. And before the break, we were talking about Samuel sitting in a hospital room, the doctors, the other clinicians not knowing where to go next. And Dr. N'Dandu, the son ended up going online and finding you. So I'll let you all continue with the story.
Yeah, please, Sam, continue.
yeah, so I live remote from my father. I live in Tampa. One of my trips, I was spending a lot of time with my father in the hospital, but I needed to take a break and come to see my infant daughter. So I was at home with my wife, continuing to do more research. I went to a different bedroom just to kind of lay there and do a lot of research, and came across YouTube and videos and saw got to one of Dr. N'Dandu's videos where he was presenting to some other physicians, explaining CLA, explaining, well, I had gotten to a point, I think it's important to say, I had gotten to a point and was so frustrated at one point that I was considering and spoken with my auntie, well, maybe we should let them amputate his foot because he's older. We can just get around by with life and start anew and just get through this. But I watched Dr. N'Dandu's presentation, and he started talking about the consequences of these major amputations and the morbidity and stuff. So I immediately kind of just, my whole mood changed. Then at the end, he gave his contact information. So he had his email and cell phone number. So I just said, you know what? I'm going to text him and email him. And I think it was within 2 hours, I got a response. We started communicating, and he said, you know, basically that same day made a commitment to work with us. And within 3 days, we were 2 or 3 days, I actually slowed him down and said, hey, before you say this, let's look at all of the pictures, all of the stuff, because I want to make sure that we're doing the right thing, that you really understand everything, and that it's going to be productive. So but he did that. I got the information over to him, all of the imagery, and we were in the hospital getting ready to do the procedure in 2 or 3 days. So took a lot of effort. There's some other stories behind that, but that's kind of how that all came about.
And
Oh,
Dr.
perfect.
N'Dandu, what was
Yes.
that like getting that text message? I mean, you had to have been like, whoa,
Yeah.
wait, what's this?
Yeah, so it was interesting, and we're going to go into details more with the next segment. But I remember it was a Sunday. I'm home, and I was on call and saw a couple of patients, and I'm home watching TV, and I get these text messages. So it's a number that I don't know, and it's the details about my father, African American male, is facing an amputation. And I saw one of your presentations. You talk about DVA. Is there anything you can do? And I was just sitting there, and I told my wife, I said, look, I just got this amazing text and I don't know this person, and look what they wrote. And so that was enough for me to know if somebody can do this, it's because they're in trouble somewhere. And to me, there's nothing more that motivates me more than that. So it was enough for me to go, not even respond by text, but I just got on the phone and spoke, and then we picked up from there. And as we come back from our next session, I'll give you the details of that conversation, what we did and how we are up until where we are today. We'll see you in the next session.
I'm going to be out of a job, Dr. N'Dandu.
That's what happened when you spend time watching Oprah Donahue in the younger days.
I love it.
Yeah,
I love it. I
yeah,
love it.
yeah.
So this one is really short. It's like, it's 4 minutes, but we can, as I said, let's get closure on the fact that what did you do? How did you save it? And, where he's at right now. And then once I close the show, we can just get the grander questions, and then I'll edit those in after.
Okay, Kim, quick question. So the next one, I'll talk about when we spoke, what we did, and I'll talk about the procedure as well. Is that what you want me to do, right?
Yes, please.
Okay, and after this session, what do we have? Can I show any slides at all? Anything, or we don't have much time left? You tell me.
If you think in the 4 minutes, you can also share the slides now. That's fine.
Yeah,
or we can just,
go ahead.
or we can just go through the basics, and then we can,
Okay, no problem.
still
So
talk
we'll
about
do,
the stuff after.
yeah,
and
I'll just
edit
go
back
to the
in.
basics of what we did, and then we'll take it from there. And the slides I kept it very, very minimum. I'm just gonna say, most importantly, really, is I want to show how things were, what we did, and where things are today. So it's really simple, very brief.
Yeah, and then we'll get just the final thoughts of where he's at. So
Okay.
in the last, we just all have to be conscientious of time, because they will cut
Yeah.
us off on the
Yeah.
radio. But just the quick, where is he at today, Samuel, and just the feeling of relief.
Yeah. Okay.
And then we can we'll stop, let Colin do his thing, and then we'll all just continue the conversation for a few more minutes to get some of the grander issues, and maybe a few other people that are on here might want to ask a few questions as well.
Okay. Perfect. No, that's fantastic. Thank you.
So this is great. I mean, there's so much to unpack here, and in terms of the emotions, the roller coaster that Sam, you must have been, going through. I mean, that it's the fight for life. It's not just a fight for leg. Like that catalyst, I love where you said, you know what, that was like, oh my God, I cannot stop now. There's literally, there's no way I can let this happen, or I'm letting my dad die.
Yeah. And Sam brought up a solid point, which happens a lot, where somebody says, instead of going through all this pain, all this hospital, they just cut the leg off and move on. And unfortunately, that's when really a lot of bad things start happening. So I'm glad, Mr. Horton has the blessing and the grace to have his son who's going to take the extra time to go find out something he doesn't know. I mean, Mr. Horton is an intellectual. He has all kinds of stuff happening, but medicine is not his field. But he took the time to go look, find out, reach out to somebody he doesn't know. No idea whether I was going to respond to him or not, but it was worth, because this is his father. And so this is what we want to encourage our patients and family members to do. This is what we have to do for one another. I mean, this is what humankind really is supposed to do. And so hopefully we can do more and more of this, for sure.
Yeah, we did. We had another African American gentleman over in Ohio that I really wanted to get to Dr. Phillips. And it was one of those things where he didn't even have wounds on his foot. There were no wounds. And he had the VA that told him that he needed an amputation, and then went to this other hospital. That was their second opinion. Was not a limb salvage center. They actually, if you look at the Medicare data, they have the highest amputation rates in the entire area. And they didn't have any options to treat him except for amputation. And I got on the phone with an out-of-state sibling who was trying to help the family that was there make these decisions and find other options. And unfortunately, despite the fact that she even got the siblings on the phone with me, they just hung up on her and me, saying, don't get involved, there's no options. A doctor's a doctor's a doctor, and we've already gotten our own second opinion, and it affirms what the VA had said. And they got his leg chopped off, not realizing that they were basically ending his life. Yeah. And so unfortunately, yeah, a few months later, his other leg became necrotic because he was laying in bed and the legs mirror each other, and he ended up getting his other leg gone, and then he was gone a month later. And it's just, I just really want to drive the point home, as you do, Dr. N'Dandu, that you don't just say, yes, ma'am, yes, sir. This is a fight for not only limb, this is a fight for life. Yeah. And you don't just settle. I know it's going to take work. I know it's hard. I know it's scary. I know it's scary. It's even scary sometimes for me, not being a clinician and trying to help someone in the hospital and not knowing how the clinicians and physicians are going to react to an advocate jumping in.
Hey everyone, sorry to interrupt. 10 seconds. So last segment, the music on this one comes out on its own. As soon as you hear it, you have 30 seconds to get out for the disclaimer.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone. Welcome back to the show. Dr. Phillips has the day off. We're here with Dr. Zola N'Dandu and one of his patients. And before the break, we were talking about how this patient ended up finding Dr. N'Dandu and ultimately ended up in a limb being saved. Dr. N'Dandu?
Okay. No, thank you. So as we picking up from our last segment, after the Hortons family found me, we spoke. I knew he was in trouble. So even before I could see his images, I was like, look, I think there's something we can do. This is before I could see the images. And Sam Horton was great in terms of trying to even give me some pictures before even the weekend was over. And so by the time Monday hit, I said, look, let's just make sure, as he said, let me get the images to make sure that you don't travel 5 hours to come and see me for me to say nothing can be done. So I got pictures of his foot. I got picture of his angiogram. I was able to look at them on PowerShare. I said, look, this is something we can definitely offer. Come on down. Sam went from Tampa to Pensacola. Pensacola drove all the way down to St. Augustine. So you can imagine that's a lot of driving, but that's what it means when you love somebody. Came down here, brought him to the hospital. He was in severe pain. Normally we do these cases with constant sedation, but we have to do it with general anesthesia because he was in so much pain. And then we did a deep venous arterialization where we connected his last remaining artery. We used the posterior tibial artery and we connected it to a posterior tibial vein. And we utilized that one vein as a conduit to deliver arterialized blood flow to a venous system to the foot. But we also opened up one of his artery that Sam had mentioned before, that when they went retrograde, that artery had shut down. We went and opened that up, even though that artery was not delivering enough blood to heal a wound. But we thought having the combination of his native arteries and the venous and the arterialized venous conduit that would create that combination is really what's going to give him a chance to heal. The hospital stay was a bit rocky because he did well. From some of the pain medicine, he got confused. After that, he had a GI bleed, but we fought through all of that. We're able to stabilize him. We're able to get him discharged. He went home initially to a rehab place to regain his strength, to deal with nutritional issues, and then he was able to go home. And throughout that whole time, we've stayed in touch. We've been texting and emailing back and forth. I know his home health nurse. He came back for surveillance angiogram to make sure the flow was good. Our podiatrist did an amputation because by the time he came to us, he already lost his second toe on the right side. He came for an amputation of the third. Now that wound is almost healed. He's pain-free. We saw each other in the office right before Thanksgiving. He walks on his own. He's doing very well. And so we're hoping in the next 2-3 weeks or so, max, we're hoping that the wounds are going to be completely healed. But I just want to thank them both for sharing their story, because this is the part that many people, especially us, me speaking as a physician, that we don't know. We do what we do. We speak amongst ourselves, but we don't know the journey that patients and family go through. So Mr. Samuel and Mr. Sam Horton, I want to thank you both for sharing your story, and hopefully we can do better at what we do in helping more patients. Thank you.
Yes, thank you, Sam and Samuel. And how are you feeling, Samuel, today?
I feel pretty good. We were out a little bit earlier today. I'm looking to buy me another car. So we're doing okay.
I love that.
Me too. Well, fantastic. And, Sam, thank you so much for advocating for your dad. I mean, you not only saved his limb, but you saved his life.
Well, we just thank Dr. N'Dandu and Dr. Piera, who is the doctor for the podiatrist, and different people. Thank you.
Thank you so much, everyone, for joining us. What an amazing story. If you want more stories of saving life and limb, go to youtube.com/@The Way to My Heart. Have a great weekend, everyone. So it'd be great if we could share, we can go into some of the grander details. If you could share the slide deck for about the procedure and share a little bit more in detail about the procedure itself. And then Samuel and Sam, I hope you can stick around and we can get into a few other details. And there's folks that may have some questions.
Perfect. Hey, Kim, let me ask you a question. Is my presentation, is it on presentation mode right now or no?
No.
Okay, let me fix that for a second here. Just give me a second here. I'll fix that.
And I love that you have your phone number again back up there. So other people that may need their leg saved in that area. The thing is, what people don't understand is this DVA procedure, it is starting to roll out. Not everyone has this Hail Mary procedure. So it's really important to recognize you may need to drive, you may need to fly. It may be something out of pocket to get this procedure, but saving the leg means saving the life.
Yeah. Am I on presentation mode now?
No.
Still no? Okay. Just give me let me stop sharing. Let me go back to it. Give me a second here. Let me do it correctly. Because I opened it. Oh, I have it open 3 places. That's probably why. All right, give me a second here. Sorry about that.
It's okay. And, for those who are online, if you do want to ask a question, I know Douglas probably wants to ask a couple of questions in there. Go ahead, just let us know in chat and we will be getting to your questions in just a little bit. And I really appreciate you guys engaging and just participating in this to, hear more of the story. Sam and Samuel.
And how about now? Is it on presentation mode?
Yeah.
Is it presentation mode? Yeah?
Yes.
Okay, great. So I want to share some of the work that we did here today. And what's also exciting today on the show, on this interview, some of my family members are here as well. So my brother is on, my mother is on, and I have some other colleagues who are also following. So this is really exciting, and obviously it's great to have Mr. Samuel and Mr. Sam Horton to share their story. So I work with Dr. Ansari, that's my partner, and we are in East Palaca and St. Augustine. And what we did before I do anything, I just want to go back to some of the things that I mentioned earlier. So as you can see here, people with CLTI, especially when you have SAD max, SAD just mean small artery disease. So we start looking at small arteries below the knee, below the ankle, and you combine that with arteries that are heavily calcified. As you can see here, 30% of patients will heal a wound at 2 years. They have a high risk of major amputation. Unfortunately, not a whole lot can be done. And you can see these arteries. So these are our toes. And in between, you're not supposed to see anything. And these are arteries that become so calcified, almost like toes. And once you get to this point, there's not really a whole lot we can do. And so medically, major amputation is one of them. The other one is palliative care, where I say, look, nothing can be done. You go home, a hospice, and that's the end of that. Or an alternative option could be foot vein arterialization. And the idea is you have an artery that's supposed to deliver blood to the foot right here. We're going to call that capillary bed. So that's the tissue. But everything's so calcified that you cannot travel. And sometimes what we do a bypass where we come right here. But in this case, you can't even do a bypass because the artery has so much calcium or they have nowhere to go. So the idea, you take an artery, you make a connection with the vein, and rather than the vein taking blood from the foot back to the heart, you use one vein to then deliver blood to the foot. And so that's what we did here. And so what I want to show is Mr. Horton's foot over time. So he had something on the left toe, not too bad, but you can see the right foot. And this is probably around October or so of last year. Then eventually it becomes like this. Then you have that. That's the tip of the right second toe. And then eventually he has an amputation, as Sam mentioned earlier, without necessarily improving the blood flow. And so what you have now is this. And by the time he came to us, this is what the foot looks like. So when Samuel mentioned, that the foot looks traumatic, you see black tissue, you really see your father just dying in front of you. And this is over a period of a few months. And so this is how we meet. And so the idea behind this, as I mentioned, was we have these arteries that were not doing anything for him, and we have the vein. And the idea was we're going to make a connection between the artery and the vein. We can either do it at a higher level, so at upper 1/3 or the lower 1/3, so we can then give flow to the foot. So when we did the procedure, we brought him in. First thing is we got access into the vein at the bottom of, so you can see the foot. I'm way here at the bottom. And we got inside the vein, took a picture to make sure that the vein was open. And then you can see, oops, sorry, I went too fast. Right here, we can see I got into the right leg by the groin side. Artery at the top looks okay. So this is hip heading towards the knee. This right here is an artery close to the knee, and right below the knee is split into 3 arteries. And you can see those 3 arteries in the beginning of them. They look actually pretty decent. But the issue is when you go to the next level, when you go look at towards the foot, that's when you see all the trouble. So here we're getting, you can see this is the ankle. So the artery to the front, to the anterior tibial, when you get close to the ankle, just comes to an abrupt end right there. It doesn't go any further. The one in the middle, the perineal, looks open, but it has quite a few bumps. But it's a small artery. It looks very small, like it's 2 millimeter here, but this artery is probably 4 millimeter. It's just there's so much plaque in there that it's not delivering much. And then the artery goes to the back. The previous hospital in Tallahassee, sorry, in Pensacola, they had opened up that artery, but there was so much calcium that when you get to the bottom right here by the ankle, they couldn't open up that area just because there was so much calcium there. And even when you open it, you just see these like dark lines, but you don't see this like the tissue here filling. So the arteries, even though some of them are partially open, they're just not delivering enough blood flow to the foot. And that's the issue. And so we went ahead and opened up this artery just to improve some blood flow there, knowing that this was just going to be part of it, but there wasn't enough. So there's some flow here being delivered, but unfortunately not enough. And we knew now that we open this, we can then use this artery that doesn't really go anywhere as a conduit, because when we connect it to a vein, we're not losing anything since it's not doing anything anyway for the foot. And so we use balloons to open up the artery. And then went ahead, took another picture to look at the vein to make sure that was okay. And then we put 2 snares. So 1 snare in the artery, 1 in the vein. And then with the needle, this is my hand wearing special leather gloves to protect my hand against radiation. Puncture to the 2 snares, put a wire, pull the needle out. And now with this wire, just like going fishing, we can lasso and pull 1 down, 1 up above, so we can make a connection. And then after that, we ballooned across from the artery into the vein. There are a couple of valves in the vein that we had to deal with. One of them was very, very, very stubborn right here, that we had to inflate a balloon and put a needle to make sure that we could break that valve, because we wanted to make sure when we put a stent there, the stent will open very well. And so that's what we end up doing. So at the end of the procedure, what you see right here is blood is coming into this artery, and you can see like a little bridge, and that's where the connection between artery and vein. And when you look at picture number 2, now you have this big tube or conduit. And then now in the final picture, now you can see there's more blood going to the foot than what we started out with. And so that was the idea behind this particular procedure, trying to save Mr. Horton's leg. So I'm going to play that picture for you one more time. You can see now we're delivering more blood flow, and this is through the venous system we just created, and the artery is still open. And so I just want to share some data with you here briefly. So there's a clinical trial that we're participating in called PROMISE-2, where we use this particular device to help patients. And over a 2-year period, these are patients that were facing amputation, where if you didn't do anything, they would get into trouble, and I'll show that in a few minutes. And in 1 year, 69% of those patients had their limbs, and in 2 years, 65% of them had their limbs. And we also did a simultaneous registry at the time called Clarity, where we took patients that nothing could be done for them. And I said, let's follow them and let's see what happens compared to those that we treat. So if you treat people, 71% in 1 year we have their legs when you look at PROMISE-1 and PROMISE-2. When you look at Clarity, only 51%. This is only amputation. But if you add amputation and death, this number goes down to 32. So meaning if you don't do anything, 68 of people within a year are either going to be dead or amputated. I mean, that's worse than breast cancer, colon cancer, melanoma, HIV. It's horrific, but many people don't know that. And so that's why we fight so hard for our patients not to end up like this. And then when you look at limb salvage, same thing as well. Here we are 2 years out, we're still here, 1 year's already here, and we're just talking about limb salvage. We're not even talking about death. As I mentioned earlier, if you add death to this number, it goes down to 32. And so Mr. Sam Horton, after he went home, went to rehab first, then home. He came back approximately 9 weeks later, and the foot looks stable. Looks actually even better than it looked before he left the hospital. We did an angiogram. Everything was still open. Our podiatrist did an amputation only of this toe rather than losing the whole leg. We thought initially maybe that he might lose all his toes. Here, it was just dead skin that came off. And then after that, actually when he had the surgery, I was in the operating room watching the podiatrist. We put a artificial skin graft right here to help with wound healing. It came back for follow-up. And this is the image of the wound approximately a month or so ago. And when he came, our podiatrist did an injection of stem cell. And actually the wound, I got some pictures earlier today that I couldn't upload to the presentation. The wound looks even better than this in terms of it's smaller. There's less depth to it. And so hopefully Mr. Horton is heading here to the finish line. But really, without the advocacy of his son, Sam, the courage that he himself had, Mr. Samuel Horton, to say, I want to go through this, and the entire team that participated in his care in terms of podiatry, infectious disease, case managers, the hospitalists here, physical therapy, nutritionists. I know the home health nurse by name, and she knows my cell phone and her cell phone. I was looking at up until now, from the time that I got the first text message, probably close to 256 text messages between me, Mrs. Sam Horton, the podiatrist, my partner, infectious disease, and a home health nurse. And this is really what it takes. But once again, I want to thank both Mrs. Sam and Mrs. Sam Horton for even trusting us to take care of them, considering all the challenges that that they went through. But we're able to do this for him, and here we are today. And I thank you for your attention.
Thank you so much, Dr. N'Dandu. That is absolutely an incredible story. And Samuel, I mean, what was the journey like from your perspective going through all of this, from the moment that your son said to you, I want to hear the conversation that your son said, hey, Dad, I think we have an option for you, but we got to go to, East Palatka, Florida and to get her done. What was your reaction?
Well, I was doing the best I could in Pensacola, basically by myself. I kept my son involved. Well, I would tell him what I was doing, but I was taking the advice of the doctors there in Pensacola who I thought were knowledgeable enough and were doing all of the things that could be done. I was kind of resigned to follow the doctors, although I've never been completely trustworthy of doctors because of another medical situation I had many years earlier, not with me, but with my wife. So I thought that, hey, you need to be critical of them. You need to watch them and try to be knowledgeable and just don't take anything they say without, questioning it. So I was keeping my son involved and, we would talk and he would say things and I would try to respond to him. But when he said that we need to do something else, that he thought that I could get a better result in another way, I trusted him. And I said, okay, that's what we could do. Of course, I got a little crazy now and then from the anesthesiologist, from what they tell me during the first operation. But I've always trusted that he had my best outlook in mind and that he was doing what he could do for my overall health. So basically, I've tried to, stay in the game, stay positive, do some of the things that need to be done. But of course, being 75 years old, I still have an honorary streak in me. Some things I just buck up against, but hopefully not too serious. So here for the past several months, I've been staying with him here in Tampa. We've been doing all of the things that we can be done. And I think we're coming out with a very positive, well, I know that we're coming out with a very positive result.
Absolutely.
I would just hope or say, if you have a son like mine or a daughter who really cares and is going to pay attention, you're blessed beyond words.
Yes,
So
sir.
that's the way I feel about this journey. I'm happy with it. And I can see that my best interests has always been in the forefront, especially with Dr. N'Dandu and Dr. Perry and what they did in this process.
Oh, no, thank you very much. Thank you. I just want to add a few words here. And you mentioned some incredible things about Sam, your son. It's a massive deal. And just to put things in perspective, so here they are. They come to St. Augustine. They have family, but in Jacksonville, which is about 45 minutes, almost an hour away. And Sam has a family at home. So Sam leaves his wife and an infant daughter home. He's sleeping here in a hospital. Her father's getting care. And he still has a job. And he's working remote. He's traveling back and forth between St. Augustine and Tampa, which is approximately about 4 hours or so. So it's not easy. But Mr. Horton, the father, doesn't get better unless Sam is here. He's been at the hospital since July, but I have to tell you, everybody remembers him. When I go talk to my infectious disease colleagues to give them an update, they know exactly who he is because father and son were here the whole time. But sometimes we see patients that come to the hospital and they're there the whole time. There's not a single family member. Either they don't have any, or they don't have the blessing, like Mr. Horton just mentioned, having, or the grace to have a child who is busy with his own or her own life, but to be at your bedside. So it's a massive deal. And this story does not happen without the son. So it's a very, very big deal. And I just want to echo those words. It is very true that Sam, you're a blessing to your father and to the rest of us. So.
And Sam, can you walk us through just the roller coaster that it is going through this whole process and being that person with this weight on your shoulders?
It's just God. Really can't really verbalize. We had Thanksgiving, and I just look back at it and say, if it wasn't for God just giving me strength and my wife putting up with it, so my job, I couldn't have done it without support from others. So I don't put it on me, because without understanding from work, from other family members, from my wife, and that wouldn't have allowed me. So I really, Dr. N'Dandu talked about other people, what might happen, but it's kind of like you really can't even look at that, because other people might not have the opportunity to do certain things or to be able to do those things. Absolutely. Even though they want to.
Yep.
So I don't really look at it. I can't. I always in my life try to not to judge others, because I don't know their circumstances.
That's right.
But I will say that you have to be, my dad said he's honorary, but because of him and because of my job, I don't take no for an answer a lot. So, and it's very intimidating sometimes. You could be intimidated if you don't educate yourself. And we're also blessed to have a lot of nurses. My mom was a nurse. My family was a nurse. So I kind of know, even though I'm not a doctor and not formally trained, I know enough to know that doctors are not infallible. And so you have to challenge them. And there's a whole different backdrop about, like you mentioned, care and billing and what's really being done and what is offered to you. There's a whole separate part of this about there was a different critical limb place in Tampa that I was going to go, that came back and told me Dad wasn't a candidate for DVA, which is a whole different story. So there's so many different levels that you just have to be tenacious in life, and you have to be tenacious and challenging throughout a process like this. And that's what I would just share with people, because I always know, or I have faith that there is options. It might not be good options. They might be challenging. They might not be high percentage, but you got to just keep on pressing. And that's what we did with help and with Dr. N'Dandu and others. We're able to be somewhat successful.
Hey, Dr. N'Dandu, was it in the box or off the shelf for this DVA?
So
You know
we
what I
did
mean?
we did an off-the-shelf DVA. And for me,
That's
uh,
which would be the
I,
different criteria, right? Different
it would be
selection.
different criteria, but for me, really, it was simple. I mean, for me, I saw somebody that needed help, and I knew I could help, and that's all that mattered. And so, to me, it's just I was going to find a way to do it one way or the other, and that's all that matters to me because when you hear the story, when you hear Sam, when you hear Mr. Samuel Horton tell the story, if you're not moved, I think there's a problem. And so for me, it was that simple. And perhaps those are things that move me. Those are things that get me motivated. But yeah, we're gonna find a way. And if I couldn't do it, trust me, I would find somebody to do it. But the one thing I wouldn't do is to let things not happen. And so here we are today.
And so, Sam, in that instance where you heard, what made you trust Dr. N'Dandu that it was possible when you had a local hospital that said, no, it's not possible?
Well, first of all, from the minute, like I said, within a few hours of reaching out to make contact, I had spoken with Dr. N'Dandu, and he made it clear that he was willing to help. He was um, he just was engaged and wanting to do something. The other place, it wasn't the people in Pensacola were basically, for the most part, clueless as far as options, or not willing to say, either didn't know or didn't want to say. I don't know to this day, but I mean, I was researching and I was using terms like desert foot. Are you familiar with desert? They act like they didn't know about any of these things, and I'm like, how could I, after researching for a few days, learn things that you don't have any clue about? And so I even had a friend, a very close friend, uh who's a interventionalist. He's a radiological interventionist, and he didn't know that much. He says, "Oh well, these DVA things, I don't know how patent it is." And me and him are we're fraternity brother. Says, "I'm not sure, but if that's what you want to do and try, you just have to have the faith that this is our option. So that's what we're going to do." So we went to the person that was willing to help us. It seemed like very educated. I looked at other videos and I knew the procedure was a valid procedure. It's not like this was the only person that was talking about this technology. So it wasn't as if we were talking about nuclear fusion that hadn't been done before. We're talking about technology and procedures that have been done in a variety of different. So here's the person that's willing to get him in, what had a sense of urgency that we needed to get there, because part of this was that the people had no sense of urgency. And after I learned about it, I'm knowing that if we don't get blood to this wound, it's going to continue to get worse. And it's obviously getting worse. And it was literally no sense of urgency. So, even with Dr. Andrew one time, he says, "Oh, well, you can wait a week. Maybe you come back next week." I said, "No, we're going to get him here right now."
Yeah.
And so that was kind of just the sense of what I was into. Let's do what we can as fast as we can. And yeah, I mean, he was the person that was willing to work with us as quickly as possible with the solution. So we had to go with it.
Yeah, it
It's
was very
interesting.
interesting. Kim, sorry, I want to add something here to that, what Sam just mentioned about urgency. So Mr. Horton had left the hospital, was in rehab. And so when we're talking about how do we get him here, so the question was, how do we get him to my facility while he's in a rehab? Does he get discharged from rehab to come here to have the procedure and then go back to that rehab? Or does he come here? So as we're talking, Sam tells Mr. Samuel Horton that, Dad, there's an option that we can do. It's going to be out of town in St. Augustine, East Palaca area, and he's in rehab. So we're trying to coordinate things. And Mr. Horton tells the folks in the rehab that They think they have an opportunity to go see somebody for another option, another opinion to potentially save his leg. As we're discussing, we have now finalized what we're going to do here. He gets discharged from the rehab place. So I get a phone call that Mr. Horton had been discharged from rehab at 5 p.m. in Pensacola. He's in the lobby with paperwork, while his son, Mr. Horton, he's in Tampa. So he has to get in the car, drive from Tampa to Pensacola, make phone calls on the way so somebody can go pick him up out of a lobby of a rehab place. And then he makes it home, I don't know, midnight, whatever time he made it there, slept. And then the next day, we're on the phone, and I know for sure, I know everything. Now it's like Tuesday, and they're driving, and they left around 9-ish, maybe or so. They were here around 5, get admitted, and even though we had direct admit, there was some hiccups there anyway, but we got him in, and the next day he was on the table. But he was sitting in the lobby of a rehab place with paperwork in a wheelchair.
They just let him go. They didn't even make sure that there was someone that would receive him. Just said, well, you're gone, you figure it out.
Yeah.
That is really
They
sad.
forced
I do
us
see
to-
this often.
Yeah, they forced us to send him out against medical authorization because we have a relative that's a case manager. My wife is in the medical profession. I didn't really know about the implications. And we told them about the procedure. We told them what we wanted to do. And we didn't want to get checked out that evening. There was some miscommunication, but they would not let him stay. I want him to stay overnight so that we could leave in the morning. I was okay if we had to do it because I knew I just had a sense of urgency that we needed to get it done. But they forced us. They wouldn't talk to the doctor. They could have called and had their doctor. Their doctor that's in charge was a vascular person, which is one of the reasons why we went to that particular rehab hospital. But even at that point, knowing the condition, they forced us to discharge him against medical authorization.
It almost feels like a little bit of a temper tantrum that you're not doing what we want, what we say. And so goodbye later.
But they weren't. That's what's so frustrating. Like, you have no solution, you have no treatment plan other than wait for him to need another amputation. That's your plan. You have not participated in trying. I even found an art assist device with balloon. I was doing I went and found this device. I had him being treated. I had to fight with them to get him to allow them to use this art assist device around his leg to try to pump blood into his foot. That was a challenge, and they had no solutions. But yet, when I presented them with a solution, it was like, oh, well, you're going to have to check him out against medical advice. Like, it's.
And that's what Dr. N'Dandu, I know you probably can't really explain the actions because it probably baffles you as well, because you're such a good soul. You have an amazing heart, and you truly are a practitioner of medicine, and you fight right alongside these patients, exhausting all available efforts. Even if you don't have the option, you're like, you know what, we're going to look to see if someone else does.
Absolutely.
And that's, I think, what's so frustrating probably for you and all of us to understand is, how is it that not everyone has this same mentality? Obviously, this is happening where a facility is throwing, in a sense, with lack of a better phrase, a temper tantrum because they don't want to be one-upped by another facility.
Yeah, that's really it. And the sad part is the patients that get caught in the middle of this. That facility is still running. They're still doing what they do. But without the advocacy of Sam driving all out there taking care of his father, he wouldn't have a leg today and probably will be on his way to dying. And so, but to many people, who knows, who cares? And so that's the challenge that we are facing. And obviously everybody's under so much pressure from left and right, whatever the circumstances are. But I think we just have to take a step back and at the end of the day realize that we're taking care of people. And the way I like to think of it is even for us who are medical professionals, we are patients in disguise, meaning our day will come. And so when I think about it that way, I just hope when my day comes that I'm ill, that I have somebody taking care of me on the other side who really cares, who wants to make sure that I'm okay, who can explain things to my family. And so I have the ability, that's exactly what I want to do for others. And so I think when you start looking at it that way, it's just part of everyday life, not a chore.
Let me
And
How do
inject,
we?
let me inject something here.
Yes, please.
I have to keep my emotions in check because today, in this time frame, I'm getting letters from these hospitals who treated me so badly, wanting me to contribute money to them. Help us with our foundation. Help us, send us money. And it just makes me very, unhappy, I say, to know that basically it's all about the Benjamins.
yeah. No, I mean, that's it's very true. I'm so sorry to hear that.
Yeah, and I'm looking at Sam right now, and you just have the most loving look on your face, and looking at your dad. What is going through your mind right now, Sam?
Just it's long process, and we're just happy. I mean, obviously, we're not at the end, and who knows what the future holds. But it's just it's amazing what you can get through and what you don't know. And we're just happy that there are people. I mean, he's right. There's a lot of things that are about money, financial. I mean, we live in a capitalist society, and medicine and in general, there's bigger issues. Like I said, I do have a friend that is a physician, and he's told me about certain procedures, and the money and why they do certain things. And I see some of the behind the scenes. Even when you talk about the rehab, he had a lengthy rehab because of some other challenges, and they were trying to get him out. And certain things happen because of the rules behind Medicare, how Medicare pays, how things happen. And a lot of people don't understand that. They don't understand why they would rather give you one amputation and keep on doing little amputations and keep on amputating you because that's easier to do than to really treat you. Like there's so many hidden incentives. Like we didn't really have in the hospital a hospitalist that had coordinated care. I will say Flagler was excellent. I felt like while we were there, we had a hospitalist that coordinated with Dr. N'Dandu and coordinated with the rest of the team and understood what they were trying to do. Whereas other hospitals, due to the corporate nature, again, my wife works at a hospital, there's medications, there's so much, again, different incentives that aren't necessarily pure to the helping of the patient. And getting back to where you're at when you're in that space, all you know is what's for your loved one. That's it.
Yeah. Yeah. No, that's exactly it. Absolutely.
And
I
what would
really,
be? Go ahead.
I really want to say, and again, that I really like Dr. N'Dandu and Pierre who worked on me because both of them give you an understanding of what they're trying to do, where you are, and what they've accomplished. And they seem to be two doctors that really, really care about what they're doing and why they're doing it. So thank you again. Without both of you, without you especially, Dr. N'Dandu, I know I wouldn't be where I am today.
No, thank you, sir. Thank you. Thank you. Absolutely.
And thank you so much to everyone, for joining us. What a powerful story. And Dr. N'Dandu, thank you so much for fighting for life and limb. And we want to get to a couple of questions. Heinz, go ahead.
Yeah, from the sounds of it, young Sam Horton there, he did all the research. In other words, he was like a Dr. Google. And I know doctors hate that. What was your thought on that, Dr. N'Dandu?
Oh, good. So, for me, actually, I love it when patients come to me with a lot of stuff. When they do the research, they come with information, when they have questions, because actually, to me, I find it makes my job easier. Meaning, I can explain things to them. They can explain to me where they're coming from. We can find a middle ground and then figure out where to go, especially in a situation like this, where it's going to be a long journey. And if you're going to do this with somebody who doesn't understand what's going on, it's difficult because they might not even know the seriousness of what they need to do, what their contribution would be or should be. And so for me, it doesn't bother me at all. I do it all the time. Patients come in, they have questions, and I tell them, you're going to leave my office. You're going to forget to ask me a question before you leave. When you go home, write them down. And whatever you have, we'll go through every single one of them, because when a patient or family leave the office, I want to make sure they leave there without questions, with all the answers. Because if they leave my office with more questions, that means I haven't done anything for them. So it's really okay. It doesn't bother me. And if somebody does their research and they come in with information that's not good for them, then actually gives me an opportunity to help them to make the right decision. Versus if I don't do that, or if I don't create an environment that can share those things with me, they're going to go home and guess what? They're going to do the wrong thing because that's what they found. And so to me, I'm very open to that. I mean, I can talk all day, so I'm comfortable with that. So I'm fine. Yes, sir. That's a great question. Thank you very much.
And earlier, if you want to address those couple of questions that he had.
I think Douglas had a question earlier.
Yes.
Is it still on? I can answer because I think the question that was asking, is it still on? No. I think the question Doug had earlier was regarding amputation or CLTI in the African American community or in some communities. So we know the association between diabetes and critical limb ischemia. We know there are some groups that are higher risk of diabetes than others, African American male and women, and then Hispanic male and women as well. And so in those high risk population, unfortunately, the amputation rate is 2 to 3 times higher, if not 4 times higher, compared to non-white Hispanic. So I think it becomes really important whenever we come across these vulnerable communities, these vulnerable patients, to be even more aggressive because we know what the implications are. And that comes from us as advocates, working very closely with our patients, with our primary care doctors, with our CLTI, with our limb salvage teams. So hopefully we can give everybody a chance to heal their wounds. But it's a problem, and we need to address that. And it goes along with the quote that I mentioned earlier, that to face our challenges, we cannot ignore them, but instead we have to address them with strength and courage. And that's how we're going to get through them and be able to address them. But yeah, definitely a much higher amputation rate in some communities more than others. In the Native American population is even higher. And so we need more CLI fighters, more CLI operators to address the complex nature of these patients. And it really takes a team to do this, as I mentioned earlier as well. So.
It really does. Thank you so much, Dr. N'Dandu. I want to finish with a few words just from Samuel and Sam in terms of convincing those physicians that might be listening, number one, to not give up on the patient, but to be okay with giving up the patient to someone like Dr. N'Dandu, who might have additional Hail Mary options to save a limb and can give a patient hope by facing those challenges dead on. And then secondarily, would love some advice that you might give to other patients that might be, and family members that might be in your same situation that you were in, to encourage them to get that strength and to not just say, yes, doctor, yes, doctor, yes, doctor, and those that are not providing the options and letting them win versus those that may have the options, may have other offerings of hope for you to really follow that journey versus the latter.
I have a question for you guys first. We don't mind answering that, but do you guys, but related, do you think that these other doctors are unaware of these? Is there a knowledge gap, like they're unaware of these alternative options, or no alternative options, or so is it an education thing, or is it unwillingness, as I think you're alluding it to leave the patient or to transfer the patient to somebody else?
From my perspective, yeah, it's a really good one. I'll let you go first.
Yeah, so combination of a couple of things here. There's definitely a knowledge gap, meaning when you talk about peripheral artery disease, there was a study that was published. I don't know exactly the number on the top of my head, but I can tell you that it was a survey, and they surveyed patients and their physicians regarding PAD. And almost 40% of patients, or primary care doctor who had patient with PAD, didn't know that the patient had PAD. So already there are so many people who have peripheral artery disease that has never been diagnosed. So many patients present to hospitals, to podiatrist's office, to cardiologist's office, finding out for the first time they have PAD is the day they have a gangrenous toe. But the process has been going on for some time. So you take that component. So there's a knowledge gap there. We don't talk about it as much. We're not educating as much. We're not talking about this in medical school curriculums or doing our trainings. That's number one. Number two, when it comes to awareness. So if you have critical limb ischemia, I mentioned your 1 year mortality is about 25%. 5-year mortality is about 50 to almost 60%. Breast cancer is 11% at 5 years. Now, how many ads you and I see in the month of October when it comes to breast cancer? A lot. It's because that community, they've done a great job, the physicians all involved, the patients, the community, and now it's become a thing, right? Nike has pink shoes. You have Real Madrid, the most expensive sport team in the world. There are times they play, they're all in pink. If you go to Miami to watch an MLS game, Messi, the whole stadium is pink. But we don't have anything for critical limb ischemia. So that's where that awareness is lacking. That's where that knowledge gap is lacking. Now, you have another component that happens. As you mentioned, corporations, you mentioned hospitals, and you have hospital A and hospital B. Sometime, because these hospitals are in competition, even if patient can be transferred from one facility to the other, those things don't happen for those reasons. But it's not the corporations that are losing money. It's not the CEO that are suffering. It's the patient. And so that's why I think it's important to really, for us to take a step back to make sure we offer the best. And if I have a patient that has a problem that I cannot treat, the treatment of my patient should not be limited by my skill set. And sometimes we see that happening. And so we need to do a better job. And so going back to what you asked, I think it's a combination of all those things that makes it challenging. And that's why people like me and other colleagues day in and day out trying to educate, first of all, ourselves in the medical community and the community at large for people to know about all the options available to them. Mr. Horton, you mentioned earlier today, if you don't know, you don't know. And if people don't know about some of these advanced options, they might just think, okay, this is the end of the road and this is it. Meanwhile, there's somebody 5-10 minutes away that can offer something else. So we need to do a better job of educating ourselves and the community. I hope that answers your question.
I agree. And I think that it is a combination of things. It is the knowledge gap that's out there, especially for early diagnosis. We shouldn't even be getting to this point of critical limb ischemia. And I would say 95% of these patients, there are acute situations. People are hypercoagulable for a variety of different reasons. And so that can lead to, it's not even possible to get that earlier diagnosis. But for the most part, the early diagnosis is really what's key here. And there is a huge knowledge and awareness gap with that. When it comes to critical limb ischemia and the treatment options available, I think that that's also a mixed bag in terms of why a doctor may offer amputation first. And I think a lot of times it does, again, come down to a lack of knowledge. They just do not know, especially in smaller community hospitals. They really are so busy that they don't even have a chance to get their head out of the sand in order to be able to learn that there might be something available. And they might have pressure from the hospital to say, hey, when we send you a patient, you're to give them what you have available, nothing else. You're responsible for that patient. And so they can only do what they can do. They can only offer you what is within their skill set. They don't even think to give up the patient to someone else. They wouldn't even know who to give them to. In a lot of hospitals, a lot of practices don't realize what another practice may be doing. They may be so busy that they don't realize, as let's say, a vascular surgeon, that maybe an interventional cardiologist that just joined their team might be doing advanced limb salvage, or an interventional radiologist, or vice versa, that a vascular surgeon might have these options available. So again, the lack of knowledge. There are some situations, though, that we have come across where the doctor has said to us, why delay the inevitable? Why would I actually go the extra mile for this patient if they're not going to quit smoking, if they're not going to eat right, they're not going to walk, they don't have the financial means to take care of themselves? So again, why delay the inevitable? And they're taking that patient's fate into their own hands. And if they're watching this video, I want to urge them, and Sam and Samuel, I want you to urge those to give up the patient. Don't give up on the patient. Give the patients the benefit of the doubt. Have that candid conversation with those patients to say, hey, we're partners in care here. I'm going to do my part, but you need to do your part. And this is what your part is. And that's also where the Global PAD Association comes in, that we can help all patients with the compliance to doctor's orders, with the accountability for walking as medicine, with the diet. We have a new series that we're launching every single Monday at 3 p.m. Eastern time, where we have a doctor who is trained in diabetes reversal, who is available to answer everyone's questions for free. So it's like you have an appointment with a dietitian every single week. We have a physiotherapist that comes on twice a month on Wednesdays, who's available at 11 a.m. Eastern time to answer your questions about walking and hold you accountable for walking. So there's so much out there that we can do as a community, all together as a village, to reduce amputations and help people live a longer, better quality of life.
Absolutely.
So Sam and Samuel, your final words.
One thing I just to piggyback off, and then I'll let my dad end it. I think it's so important. One of the things in the process and doing the research is, and I hold myself accountable, is that when your loved one has a condition, whether it be diabetes, or my mom had mixed connective tissue disorder, whatever that condition is, you yourself and the doctors need to kind of brief them on the complications, what kind of things, like, here's what this looks like going forward. Like if you get pre-diabetes, what really happens to diabetes patients? Like, what are those complications? So you understand the seriousness of it. I think a lot of people do not understand that diabetes leads to arterial disease, and arterial disease is a part of kidney failure, and you get to you end up on dialysis, and what that means for your overall health. And that goes for a myriad of other ailments. And you kind of alluded to, a lot of doctors don't talk about what your diet and what that really means for your longevity, because they just assume that you won't comply and they just give up on you. So I would advocate for doctors having frank conversations with the patients and the loved ones about, you know, prognosis and what you can do to, maybe if you can't reverse, but you can delay, and not just say, hey, here's a pill, go take this pill, knowing that that pill might not be delaying it, that the lifestyle changes can have a much more impactful result than just simply giving you a medication and saying, oh, well, you got diabetes, doesn't matter. Because I oftentimes think that patients don't truly have an understanding of what that means to their future.
Yeah.
And so I would just advocate for them to have those conversations so that they can have these preemptive things, so they don't get to even the point where we need lifesavers like a Dr. N'Dandu or a Dr. Piera, because I'm sure that some of these things, they might not be able to be completely prevented, but maybe they're delayed.
Yep.
Thank you so much. We really appreciate you guys sharing your story. It means a lot. And I hope that this leads to more limbs saved, people who are, you know, find this story and they're able to either call Dr. N'Dandu directly or be able to call our Lifesaver hotline. Anyone across the US can call our Lifesaver hotline at the Global PAD Association at 415-320-7138. That's 415-320-7138, or go to padhelp.org. We can help patients across the globe find expedited limb and life-saving care. So please make sure to check that out and don't settle for less than what you deserve, which is that better quality of life. Thank you everyone for joining us.
Yeah, and Sam, Kim, we're gonna have hopefully Mr. Samuel Horton give us the final words as we're heading out.
Hello. You didn't have anything else to say?
Well, I guess I'd end up by saying, basically, you have to fight and fight. Don't give up. Don't give in. It's your life, your health. And if you don't take care of yourself, whom do you expect will? Everyone have a great day.